morning. My name is Ashisha. I'm row number 1. Today we are going to have a seminar on upper limb and its clinical cases. These are the presenters for today. Weight transmission in upper limb. The cause of weight transmission is from hand.
Hold the mic close to your mouth.
It is from the hand to the wrist joint, to the radius of the ulna by the interosseous membrane, then it passes to the elbow joint and the humerus, and through the shoulder joint it reaches the scapula, and reaches the clavicle through coracoclavicular ligament, and ultimately it reaches to the exoskeleton by costoclavicular ligament and sternoclavicular joint. Even though the primary function of upper limb is not weight bearing, it does so in functional activities like pushing, pulling while using clutches, or in foosh injuries. What is foosh? Foosh injuries are caused when a person falls on outstretched hand. It can be caused due to slipping, fall from height, sport injuries, and road traffic accidents. The areas prone to foosh injuries are wrist joint, the forearm bones, the humerus, and the clavicle. In the wrist joint, scaphoid is the commonest bone to be fractured. In the forearm bones, the fracture of radius can be classified into Smith's fracture and Colles fracture. In the humerus, it is common as supracondylar junction, causing supracondylar fracture of humerus, and in the clavicle, causing fracture of clavicle. Thank you.
Good morning to one and all. I am Master Abhishek Turukmane, roll number 2, and my topic for today's seminar is clavicle. Clavicle is a modified long bone of shoulder girdle. It is also known as collarbone or beauty bone. It lies horizontally in the root of neck. It connects upper limb with axial skeleton by joining sternum medially and scapula laterally. It helps in supporting the shoulder, keeping away upper limb from the trunk, and also the transmission of weight from upper limb to the sternum. Now there are some peculiarities of clavicle which make it different from other long bone of body. It is only long bone which plays horizontally. It is subcutaneous throughout its length, so we can easily felt it under the skin. It first bone to ossify starting 5th to 6th week of intrauterine life. Unlike other long bone, it ossifies mainly by intramembranous ossification. It has two primary ossification centers, one for lateral part and another for medial part. It has no medullary cavity, which is unusual for long bone, and it is pierced by middle supraclavicular nerve, which says sensory supply to the skin over the clavicle. Now I present a clinical case in which see a 40-year-old man while cleaning the wet marble floor slipped and fell on outstretched hand. There was no loss of consciousness and no shortness of breath or chest pain. He was able to move all the finger, wrist and elbows, and no other injury were noted. On examination, the surface over his left clavicle was tender and swelling present over the left clavicle. He was unable to raise left arm due to severe shoulder pain. His chest and shoulder radiograph show abnormality in clavicular region. We can see this radiograph. It is a normal clavicle in which we see the clavicle is smooth and continuous. This is the radiograph of our patient in which see his clavicle is fractured. So we can interpret this from our patient has fracture of left clavicle. So mechanism of this injury is fall on outstretched hand. When we fall on outstretched hand, the weight of upper limb is transferred to the clavicle and the clavicle get fractured because it is thin and also curved. So for next explanation, I will invite Shrutika. Thank you.
Good morning, respected faculties and my dear friends. I'm Shrutika Adbalwar, roll number 3, and I'll be presenting a seminar on clavicle. Abhishek just presented the case and I'll be elaborating that further. So he said about the injury. So these are the potential sites of the clavicular injury. These can be the medial end, the lateral end, or the middle part. But among these, the most common site is the junction of the curvature between the two bone at the bone. Okay. What makes this point the weakest point? So basically the structure. The clavicle is convex forwards at the medial part and it becomes concave forwards at the lateral parts. Due to this structural change, the junction point becomes the weakest point. That is the point at which the medial 2/3 and the lateral 1/3 point meet each other. So along with this, supraclavicular nerves also passes through that point. Because of that, that area becomes less protected as compared to the entire bone. And thus, this part is also the thinnest and the weakest part, and it also has no strong ligamentous support and the muscular support, which adds more and makes it a potential point for the fracture. Then moving onwards, so he said that 40-year-old uncle, let's call him Suresh uncle, he has fallen on marble floor and he has got an injury. So let's see what happens after he has injured himself. So first of all, the sternocleidomastoid will pull the medial part upwards and the middle bone, the middle part of clavicle will look elevated, and the trapezius alone is not able to hold the weight of upper limb alone. So that's why the lateral part will get displaced downwards. And in severe cases, the lower trunk of the brachial plexus is also affected, specifically the ventral rami of the C8 and T1. So now uncle has fallen, he has taken to the hospital and now he is being treated. Depending upon how severe is his injury, his treatment to him is given. So if the fracture is a non-displaced type of fracture, as you can see over here in the X-ray, he can be treated with a conservative treatment such as a sling or a figure of 8 bandage. And in this, it will provide the stability and it will help in the healing process. And if the fracture is a severe one, if it's a displaced one, a reduction is required to be performed. It can be open type of reduction or a closed type of reduction. In open reduction, screws and plates are used. Then we have the clavicular fracture is over, and now we are continuing with cleidocranial dystosis, in which the clavicles may be congenitally absent or they may be imperfectly developed along with the defective ossification of the skull bone. In this condition, the shoulders can be approximated anteriorly in front of the chest. I have a video of it, so I guess everyone knows this guy. Just a moment. So he's able to take his shoulders anteriorly as we don't have clavicles in him. So I'm done.
Good morning, respected faculty and all of my batchmates. I am roll number 5 and I will be presenting a case on the fracture of the neck of humerus.
You can stand here.
Before discussing the clinical case, I would first like to give a brief overview of the general anatomy of the upper end of the humerus. It is marked by the presence of two tubercles, the greater tubercle and the lesser tubercle, of which the lesser tubercle is located more medially. A head is present that is directed medially and posteriorly, and there is the presence of three necks, that is the surgical neck, the anatomical neck, and the morphological neck. The surgical neck represents a thin border that lies at the junction of the upper end and the shaft of the humerus. The anatomical neck represents the boundary between the head of the humerus and the rest of the upper end of the humerus. And the morphological neck represents the junction of the diaphysis and the epiphysis at the upper end, which is only present in children and disappears in adults after diaphyseal fusion. So now that we have a brief overview of the anatomy, let us discuss the fracture related to this area, that is the fracture of the surgical neck of the humerus. So we have Mrs. Geeta, who has reported to the casualty department in a hospital following a fall in the bathroom. She reports of pain in her right axilla and was brought into the department supporting her right limb with her left hand. Upon physical examination, it was reported that she was not able to move her arm in adduction because of some muscles affected. She was referred to an X-ray to further see what anatomical defect has occurred. As the X-ray is visible here that the shaft of the humerus has been fractured. As we can see, the shaft has been displaced medially and anteriorly. The X-ray was taken in AP view, and the displacement occurs the shaft has been displaced medially and anteriorly because of the pull of the pectoralis major muscle that is inserted at the intertubercular sulcus. So the final diagnosis was concluded to be a surgical neck of the humerus fracture. The mechanism of injury was said to be a Fuchs injury or a fall on the outstretched hand. The surgical neck is the most prone site for fractures because of contrasting forces at the glenohumeral joint and indirect forces transmitted from the elbow joint. Thank you. Now the rest of the case will be presented by my batchmate Aditi. I'm roll number 5. Thank you.
Good morning everyone. My name is Aditi Singh and I'm roll number 4 and I'll be continuing with the case. So the X-ray which was presented by Ramit right now, it showed the fracture of the surgical neck of the humerus. But what is important to note is the fact that the damage does not merely stop at the shoulder, at the fracture of the bone itself, but rather extends to the fact that there are two very important structures which pass behind the neck of the shoulder, behind the neck of the humerus, which is the axillary nerve and the posterior humeral circumflex artery. So before talking about how it's affected and what are the complications arising due to it, let's first talk about the normal course of the axillary nerve and the vessel. The axillary nerve, as we all know, it's a branch of the posterior cord of the brachial plexus, which arises in the axilla and passes posterolaterally into the quadrangular space, and there it divides into two divisions, which is first is the anterior division, which supplies the deltoid and the skin over the anteroinferior region of it, and the posterior division, which supplies the teres minor. Now the normal course of the posterior circumflex humeral artery, it's a branch of the third part of the axillary artery and it follows the same course as the axillary nerve. It also passes through the quadrangular space, supplying the shoulder joint and the muscles of the quadrangular space along with the deltoid muscle. So how are these structures exactly affected? There are these sharp fragments of the bone which is caused due to the fracture, and these sharp fragments, they can either pierce the nerve and they can lead to its tearing away or stretch or compress it. Therefore, that leads to one of the most major consequence of it, which is loss of the innervation of deltoid muscle and the teres minor. Since there is paralysis of deltoid, the patient realizes something very shocking. That is that he cannot abduct their hand sideways. Indeed, they can start the movement from about 0 to 15 degrees thanks to the supraspinatus, but above that nothing happens. Also, over the time you can see that there's loss in the appearance of the shoulder region. Our normal shoulder, it is rounded in shape thanks to the intact deltoid muscle. But once the deltoid muscle is paralyzed, it leads to wasting away of the muscle. And this wasting away causes the shoulder to become much more flattened in appearance. So even when the patient approaches you from far away, you can see that there's something clearly wrong with the shoulder. Also, another classical sensory loss complaint is the loss of sensations over the regimental badge area. This is clinically very important because it helps us to rule out any other lesions and focus just on the axillary nerve. Also, there's loss of lateral rotation, but not a lot because there's infraspinatus also aiding it. And since there's also rupture of posterior circumflex humeral artery, it leads to leakage of blood all over that area, giving it a much more swollen appearance and increased pain. Indeed, our body is supplied by enough blood backup so as to prevent major tissue death, but yet, due to this rupture, it leads to delayed healing and increased pain. So how do we treat the patient? There are two methods. First, if the injury is not so severe, then we move forward with the conservative method, which is the sling method. It involves immobilizing the shoulder. And the next one is the open reduction internal fixation method, which is only done when the injury is severe, which is if the bone is damaged and there are multiple fragments of the bone or displacement of the bone from its anatomical position. So, our doctor decides to treat Miss Geeta with open reduction and internal fixation after reviewing the seriousness of the injury. And that's how Mrs. Geeta will be treated. And we wish her a speedy recovery. Thank you.
Good morning, everybody. My name is Arisha Sheikh, roll number 6. Today, my topic for seminar is fracture at mid shaft of humerus. So, before beginning with this, we'll see a clinical case. A 45-year-old male was brought to an emergency department after a road traffic accident. He had pain, swelling, and deformity of the left arm. On examination, inability to extend the wrist and fingers, weak supination of the forearm. However, elbow joint permitted weak extension. Loss of sensation over the dorsum of the hand. X-ray showed fracture at mid-shaft of humerus. So before beginning with the clinical case, let's see where the actual fracture lies. Mid-shaft fracture of humerus. Fracture involving the mid-third of the shaft of humerus, commonly associated with a radial nerve injury that is at the posterior surface of the humerus, where there is a radial groove lies the radial nerve. So it is commonly associated with radial nerve injuries. The fractures can be either transverse, oblique, or spiral. Here we have a radiograph X-ray of AP view of a normal humerus, and there is an abnormal humerus having fracture at the mid shaft. The mechanism of injury. It can be either direct trauma, which is basically from the road traffic accident, which is the most common direct injuries, and then we have an indirect trauma, which can be from a fall or outstretched hand. And then we have Huston's Lewis fracture, a specific distal 1/3 spiral fracture that possesses a high risk of radial nerve entrapment. As I read the first clinical case, which was this one, we may get questions in our exam like identify the deformity, which structures are most likely to be injured in this condition, explain the anatomical basis of presenting symptoms, explain the elbow joint is possible in this condition, explain the anatomical basis. So yeah, now the further explanation will be given by Arvind. Thank you. My roll number 6.
A very good morning to one and all present here. My name is Arvind Bishnoi. My roll number is 7. So the general complication of the mid-shaft fracture of humerus are non-union, in which the bone fails to heal, malunion, heals with deformity, laterogenic palsy, nerve damage caused while doing surgery. It also the radial nerve injury. The muscles affected are triceps, brachioradialis, and the paralysis of the forearm, extensors of forearm, such as carpi radialis, extensor digitorum. The functional loss involve wrist drop, finger extension weakness, thumb extension loss, and loss of sensation. The diagnosis involve X-ray, nerve diagnosis, and the treatment are plaster, physiotherapy, the ORIF, which stands for Open Reduction Internal Fixation. Thank you.
Good morning everyone, I am Akhil Chavan, roll number 8. Together with roll number 9, we are going to present a clinical case on supracondylar fracture. Beginning with the case, a 7-year-old boy is brought to the emergency department with pain, swelling and deformity of the left elbow following a fallen outside hand that is pushed while playing. He is unable to move the elbow due to severe pain. The question arises are the diagnosis, mechanism of injury and which nerve is most commonly injured in this condition.
बेटा थोड़ा माइक जवळ पकड.
We will see this condition ahead. Beginning with the sign and symptoms, severe pain around the elbow following trauma, which can cause the periosteum tear, cause the fracture of the bone, also the due to irritation of anterior interosseous nerve, which is a branch of median nerve. Swelling due to soft tissue injury and bleeding is seen. Restricted elbow movements due to pain and fracture instability. Visible deformity of elbow, commonly posterior displacement of distal ligament, caused due to olecranon, which act as fulcrum causes posterior displacement of distal fragment, also cause of the strong pull of triceps muscle. Mechanism of injury, as seen earlier, is push, fall, and outstretched hand. Extension type is most common due to hyperextension of elbow. Moving to the radio diagnosis, for proper diagnosis, two types of views are mandatory: anterior posterior and lateral. The anterior posterior view shows us if there is displacement toward the lateral or medial side. Lateral view show if the displacement toward anterior or posterior side. As seen in the lateral view, it's shown posterior towards the anterior side, and in the anterior posterior view, lateral deviation can be seen. Anterior humeral line does not pass to the middle one-third of capitulum. It's an important distinction, as normally it passes through middle one-third of capitulum, which is an knob-like structure present anterior to the humerus, over which radial bone lies. Confirming the date of supracondylar fracture, let's see the definition. What is supracondylar fracture? It's a fracture of distal humerus just above the condyle, commonly seen in children of age group 5 to 10 years. It is most common in children as proper less mineralization of bone and porous bone in children, also due to frequent falls in children. Towards the elbow, we see a 3-point bony relationship which formed because of 3 bony landmarks, that is medial epicondyle, lateral epicondyle, and oligranal process. Imaginary triangle form shows lateral epicondyle, medial epicondyle, and oligranal on the angle of the triangle. At the flexed 90-degree position, they are present in the isosceles triangle, and when the elbow is extended, it is present in the straight line. It is of important clinical diagnosis, as when there is a fracture, this distal fragment is moved to a posterior or anterior side, it causes a distortion of the triangle, and it helps the clinical diagnosis. Sumit will continue.
Good morning everyone, my name is Sumit Aware, roll number 9. I will present short seminar on supracondylar fracture of humerus and will mainly focus on complications and treatment. So complications are divided into 2 parts, early complications and late complications. In early complication, first is brachial artery injury, which causes reduction in blood supply to forearm. Then second is median nerve injury, and third is compartment syndrome, which is serious. The late complications, first is cubitus varus deformity, also called as gunstop deformity. Then second is elbow stiffness, and third is Walkman systemic contraction, which is most serious in late complication. Then coming to median nerve or anterior interosseous nerve injury. Median nerve injury presents with weakness of forearm flexor muscles, and anterior nerve injury is detected by using OK sign. OK sign checks are first is flexor pollicis longus of thumb and flexor digitorum profundus. Flexor digitorum profundus of index finger. Then if the patient is unable to do OK sign, it indicates AIN pulse. Coming to Folkman's ischemic contraction. Folkman's ischemic contraction is permanent flexion deformity, permanent flexion deformity in wrist and fingers, which is caused by loss of blood flow to forearm. Then its common causes are supracondylar fracture itself and very tight cast, which cuts off the blood supply. Then in pathology muscle damage leads with scarring, and then muscle shortens and hand get fixer. Then its early signs are severe pain, swelling, and pain when fingers get stretched passively. Its late signs are claw-like hand deformity with some nerve problems. Then coming to treatments, initially the first step is pain relief, then immobilization of fracture using above elbow splint, and then most important is neurovascular check. Neurovascular check includes skin color, then movement of fingers. If the fracture is undisplaced, then treatment is conservative with the above elbow plaster slab. And if fracture is displaced, then treated by close reduction followed by K-wire fixation. Surgery is needed if the blood flow is not restored or fracture is still unstable. Next one.
Good morning everyone, my name is Radhika Ramesh Babar, roll number 11. So today's topic presentation is Kohli's fracture. So before diving deep into the topic, I have a case. Mrs. Suman, a 62-year-old postmenopausal woman, slipped on the wet bathroom floor and fell forward, landing on her outstretched right hand. Immediately after the fall, she complained of severe pain and swelling around the wrist joint. On physical examination, there was visible dorsal angulation of the wrist, giving a dinner fork deformity. Movements of the wrist were painful and restricted. So, listing the signs and symptoms, she experienced severe pain, bruising, swelling, and the wrist was hanged at odd angle, and she was not able to rotate her wrist joint. And on seeing her radiograph, so this is the normal X-ray where all the bones are in the normal position, and this is the Kohli's fracture X-ray where we can see the radius is dorsally angulated. So from all the radiograph signs and symptoms, we can conclude that the case was about Kohli's fracture. So what is the anatomical basis? So as Ashna mentioned that Kohli's fracture is most commonly caused during fall of outstretched hand. This happens because when person falls in outstretched hand, in order to save himself, he dorsiflexes the wrist, which causes the ground reaction to travel from radius and ulna. So why does radius get fractured? Because the 80% of weight transmission goes to the radius and 20% goes to the ulna. And most commonly the distal metaphysis fragment is fractured because it has majorly spongy bone, which makes it more fragile. So here the reason to mention the woman was postmenopausal, because in postmenopausal period, the estrogen levels are really low in the body, which causes less calcium absorption, so which makes the distal part more fragile. So the postmenopausal women and osteoarthritis patients are more prone to the force injuries, so which results in dinner fork deformity. So what is the complication that is faced is carpal tunnel syndrome. So as we all know, this is the carpal tunnel, and the roof, floor, ulna, border contents, we are all familiar with it. So what is more concern for is median nerve. The median nerve motor supply is for thenar muscles, lumbricals, and sensory supply is the palmar aspect and dorsal aspect. In the carpal tunnel syndrome, there is the compression of median nerve under the flexor retinaculum, which goes from the scaphoid bone to pisiform bone. It results in the numbness, tingling, and weakness in the mentioned areas. And also, the cutaneous sensations are intact because the palmar cutaneous branch of median nerve passes above the flexor retinaculum and not from the flexor retinaculum. And the thenar, the person also might experience the thenar atrophy because of long-term compression of the median nerve. How is the Kohli's fracture managed? Is by the conservative method is Kohli's cast, and the surgical treatment is ORIF, that is open reduction and internal fixation. Thank you.
Good morning everyone, my name is Samiksha Badure, roll number 12. Today's my topic is Smith's fracture. Firstly, we will discuss about one clinical case. A 40-year-old woman present to the emergency department after a fall on flexed wrist while sleeping in the bathroom. She complains of severe pain and swelling over the distal forearm and wrist with the inability to move wrist and hand. On the examination, swelling and tenderness over the distal radius, visible palmar deformity at wrist, that is guidance by deformity. Wrist movements are painful and restricted. Radial artery pulsation is palpable. No sensory deficit in the finger. Here you can see a guidance by deformity. So we can conclude that the above case is Smith fracture. Mechanism of the Smith fracture. When a person falls forwards or backwards, typically during road traffic accidents, sports injury, fall from height, hand hits the ground with the wrist in a palmar flexion, a force transmitted from the metacarpal to carpal and carpal to the distal radius. Distal part of the radius gets felt under compression, resulting in the displacement of the distal fragments anteriorly. In both Smith's and Kohli's fracture, distal radius get fractured. Then what is the difference between them? In the Smith's fracture, a person fall on outstretched hand with the palmar flexion, and in the Kohli's fracture, a person fall on outstretched hand with the extended wrist. Here Distal fragments displaced anteriorly, so garden spray deformity is seen, and the college fractures, distal fragments displaced upward and backward, so the dinar 4 deformity is seen. In the garden spray deformity, dorsal prominence of the distal end of the distal proximal fragment is seen. In the dinar 4 deformity, angulated deformity is seen. Radial artery pulsation in Smith's fracture. Radial artery pulsation is usually present in the Smith's fracture. It may be diminished or painful, but not absent in most of the cases. Radial artery pulsation is palpable using 3 finger techniques. One is middle, one proximal and distal fingers. Proximal fingers kept on the compresses the artery and control the blood flow. Distal fingers help the confirm that the pulsation is arterial and not transmitted. Middle finger kept over the artery and actually feels the pulsation. Treatment of the Smith's fracture. Treatment of the Smith's fracture is using cast treatment. Thank you.
Good morning, my name is Nishant and I am going to present the fracture of the scaphoid bone. Scaphoid is one of the seven carpal bones which is placed obliquely just below the radius and articulating with the lunate and the trapezium and trapezoid. We can see that it has a single bony landmark which is the tubercle of the scaphoid and rest is the body of the scaphoid. At the junction of the tubercle of the scaphoid and the body of the scaphoid, the region is called the west of the scaphoid, which is the narrowest part of the scaphoid bone. With this, we can start with the clinical case. 22-year-old male presented with pain over the right wrist after a fall on an outstretched hand while playing football. The pain is localized to the radial side of the wrist and increases with wrist movement and gripping. On examination, there is tenderness in the anatomical snuff box with restricted wrist movements. Especially extension, no obvious deformity is seen, and neurovascular status is intact. On the filming of the X-ray, the X-ray showed it appears like that the scaphoid bone is. It appears like there are two bones in place of the scaphoid. The most common site of the fracture is the west of the scaphoid because it is the narrowest part of the scaphoid bone due to the junction of the tubercle of the scaphoid and the body of the scaphoid. And the most common cause of the fracture is also due to the fall on the outstretched hand because when there is a fall on the outstretched hand, the weight transmission is through the radius, and due to the direct articulation of the scaphoid with the radius, it projects two vectors. One which goes slightly upwards, which projects the body of the scaphoid a bit upwards, and the tendency of the scaphoid tubercle is to go downwards, which causes the fracture at the west of the scaphoid. The fracture of the scaphoid can be felt by the tenderness on the anatomical snuff box, which medial border is marked by the extensor pollicis longus muscle, and the lateral borders is by the adductor pollicis longus and the extensor pollicis brevis muscle. And at the base of the anatomical snuff box, the scaphoid is located. So due to any pathology at the scaphoid bone can be felt at the anatomical snuff box. Here the scaphoid is placed here, and in the normal surface anatomy it is here. In the normal and the fractured, generally the scaphoid fracture is not seen in the X-ray, but if seen, it appears as two different bones at the place of the scaphoid. And we can also see that there is a fracture at the west of the scaphoid. Scaphoid bone has a unique blood supply, where it is supplied by the radial artery branches, and it enters the scaphoid from the distal end and not from the proximal end, which causes the most common complication of the scaphoid fracture, which is the avascular necrosis of the scaphoid. Because when there is a fracture of the scaphoid, it disrupts the supply of the blood at the proximal end of the scaphoid. And the treatment for this is first the conservative method, which is the glass holding cast, in which the hand is placed at the glass holding position. And the treatment for the scaphoid is generally surgical, which is first scaphoid screw, which articulates the physical articulation of the scaphoid fragments, and then the vascular scaphoid grafting.
Good morning everyone. My name is Sanjay Bodke, roll number 15. I will discuss different types of elbow injuries. In elbow injuries, we have golfer's elbow, tennis elbow, student elbow, and pulled elbow. I will discuss golfer's elbow. The structure affected in golfer's elbow is the middle epicondyle, and the mechanism by which it affects is the micro tear of tendon origin and disorganized collagen fiber. The treatment is eccentric loading splinting, by which we just lower our flex wrist against the resistance, which causes the organization of the tendons and the collagen fibers reorganize. Now that I will discuss tennis elbow, the structure affected is the lateral epicondyle, and the mechanism is same as the golfer's elbow, which is micro tear of the tendon origin and disorganized collagen fiber, and the treatment is eccentric loading splinting. In student elbow, the structure affected is olecranon bursa, and mechanism is inflammation of the bursa. Treatment is non-steroidal anti-inflammatory drug aspiration. Now we will see the anatomy of annular ligament, which covers the radius of the head of the radius. In pulled elbow, the structure affected is annular ligament of the radius, and the mechanism is subluxation of the annular ligament, which causes the partial dislocation of the radius. Treatment is supination flexion method. And the question is why it is common in children, because the radius head is not well developed, and the annular ligament is loose. Thank you.
Good morning everyone, my name is Aditya Bhore, roll number 13. Let's summarize what we have learned till now. We have seen first of all clavicle. The most common site of fracture in it was the medial 2/3 and lateral 1/3. And then we have moved to the its a clinical case like cleidocranial dysostosis, in which the clavicle was absent or imperfectly developed, and because of which the shoulders were anteriorly approximated. Then we moved to neck of humerus, in which we have seen anatomical neck, surgical neck, morphological neck, and injury to axillary nerve. Then the third one was mid-shaft fracture. In it, the common site was the medial third, and injured nerve was radial nerve, which is present at the spiral groove. And we have seen the case of wrist drop in it. Fourth one, we have seen supracondylar fracture, 3 bony relationships, and structure affected in it was medial nerve and brachial artery. The fifth one was Colles fractures, Smith fracture, and comparison between Colles fracture and Smith fracture. In scaphoid fracture, we have seen the most common site was waist of scaphoid, and in it we have seen a vascular necrosis of scaphoid. Then the last one, we have seen different types of elbow injuries like tennis elbow, golfer's elbow, student's elbow, and pulled elbow. And thank you.
Excuse me, what is this? किसने डाला है वो? Please explain.
From speech directly, it is going to the Broca's area.
Very well presented by first team, that is roll number 1 to 15. Yes, ma'am is asking something. Can anyone explain how things are going like this? अरे बच्चों, इधर मैम ने कुछ क्वेश्चन पूछा है आपको, ये क्यों रखा है?
So suddenly we are going from the upper extremity to the brain. So what is the connection here?
Why she has put it here?
Yes.
Any logic? What? Read it.